Okay. Good morning. Sorry, my computer was rebooting as soon as I turned it on. So I hope everyone's doing okay. Okay, so yesterday when we stopped, basically we talked about the stages and planes. And for the test, I want you to be able to, and I'll kind of determine when the test is going to be, get a feel for where we're at. But you know, when we talk about stage 3, which is normally when they've entered general anesthesia, appropriate for the procedure. Remember, like when you guys sedate for radiology, your patients are going to be in varying levels of stage 1. That's sedation. There's light sedation and there's heavy sedation, but when they're sedated, they're only in stage 1. Now, if you're going to put them under general anesthesia for a procedure, you give an induction agent to move them through stage 3 to get them to stage 3. And remember, stage 2 is a rapid. And hopefully, if you do a good induction, you don't even see stage 2. You could go right from stage 1. I mean, they pass through it, but the goal is that's excitement and disorientation. And the longer a patient is in stage 2, it's stressful for the patient, stressful for you. I've had animals, I've had to like squeeze their mouth shut and they're screaming and I'm like yelling at the person to like give the drugs because he's paddling, snapping, screaming. It's not a fun place to be. So hopefully we get to this stage 3 and then, there's stage 3 plane 1, which is light, stage 3 plane 2, which is where you want to be, which is surgical. Stage 3 plane 3 is your deep. And then when you get much past that, we're like in overdose level. We have to do something to get the patient out. Now, our goal, obviously, when we keep them in surgical anesthesia, that's your job, is that, they're not moving. We don't think they're aware. And how would I know they're aware? They're going to react, potentially moving, potentially heart rate, blood pressure. Things are going to react to surgery. And then I'm not where I need to be. So I don't want them to recognize it. I don't want them to feel pain. How do I know they're feeling pain? Blood pressure, heart rate go up. Potentially they're moving. Now this last one, which is, are they aware of the procedure? This is very important in human anesthesia. One of the drugs that we get there that we give to people, which is called Versed, which is midazolam. Now we use midazolam in animals, but we use it in people. One of the effects of midazolam is it's an amnetic, meaning it gives amnesia. You always hear stories of people remembering conversations in the OR, and you hear, things that, did they, you don't want a memory of the procedure. And if you add midazolam to a protocol, it's supposed to, help you forget or not remember. And now I can't look at my dog and be like, oh, did that spay suck? But if they are reluctant after the procedure for interaction, if they're cowering, if they act like they don't want to go to the vet, we're trying to do a good protocol so that the animal, is handleable, wants to still interact, comes back to the clinic, doesn't have, aversions. So, and let me give you a little example. My old dog, Ozzy, that I used to have, one time he tried to go into the basement. He was very young, and there were wood steps into the basement, and he slipped and fell, like down some steps. I could not get that dog to go into the basement ever again. Like, we'd had a tornado warning. I literally had to, my son had to pick up the dog, and I'm like, carry him down because he will not come down the basement steps. He remembered falling down those basement. And I think all of you could probably think about something, that your animal does where they're like, Bo will not come to the stove if I'm frying. If he hears frying, he got splashed once with, bacon popped, and I think he cried. And, now if he hears the range hood, the vent fan, or if he hears frying, he literally will stay in the family room and watch. And he just got burned the one time by the stove. So what we're saying is animals do have memories of things and do associate things and have avoidance. So we're, you know, a good protocol will hopefully prevent that from happening. Now, when we do monitoring, there's different ways to monitor. And there, every time I talk about a vital sign, like when I talk about monitoring the heart and respiration, there's always a physical way to do it and there's a mechanical means to do it. Now, we tend to use both. Like when you're in surgery, you're going to use an electrocardiogram or an EKG, blood pressure, capnograph, Doppler, pulse oximeter. Those are all mechanical means of monitoring a patient, but they never should be a replacement for human intervention and human monitoring, which is feeling the patient by touch, listening to the heart, you know, watching, like, are their eye position? Am I seeing movement? So, and I think a common mistake that students get into, especially when you get into surgery, is you tend to stare at the monitor and you tend to just look at your mechanical equipment. Um, you know, the student I was helping the other day, the ECG was kind of all over the screen because the student was scrubbing for surgery. So the ECG was moving. Therefore, the heart rate kept jumping. It was like 70, then it was like 220, then it was 140. And she's like freaking out because she's like, oh my God, like I don't understand this heart rate. I don't understand this. What is happening? And I said, don't look at that. Put your stethoscope in your ears. And when she listened, the heart was just very regular. And she's like, it's not even doing that. I'm like, but watch what's happening. You have someone scrubbing, so the leads are shaking, and therefore your ECG is all over the place. So like monitors are useful, but I said, I don't want you looking at the ECG and taking your heart rate from that. I want you listening to the heart actually beating. That's going to be more accurate. That's the heart rate. So mechanical instruments aren't, you know, you have to know both. You have to know how to monitor physically and mechanically everything I talk about, but I will talk about the pros and cons. And I don't want you to get stuck because some of you may go to a clinic, you know, you're going to use these monitors when you're in surgery rotation, but you might go to some podunk clinic that doesn't even have an EKG, you know, and you have to understand, how am I going to monitor the patient if I don't have all of those bells and whistles? It's doable. It's definitely doable. So how we break it down is when we talk about vital signs, you can talk about what affects circulation, which you've got, you know, heart rate and rhythm, pulse, CRT, mucous membrane color, blood pressure. If I asked you, what are ways we assess circulation under anesthesia? This is what I would want you to tell me. If I say, what are ways that we monitor oxygenation during surgery? Then this is what you know, mucous membrane color, refill time, hemoglobin, inspired oxygen, arterial oxygen, and then how do we monitor ventilation? Now, ventilation and oxygenation are tied together. Ventilation, though, is bringing in oxygen and removing CO2 the other way. Now, if my animal is breathing in and out, I would assume they are oxygenating. But the problem is, bringing in the oxygen is only one part of the equation. Okay, when oxygen goes into the alveoli, then it has to diffuse into a capillary, and then circulation is what takes oxygen to the tissues. So you could have a circulation issue that is affecting oxygenation that has nothing to do with ventilation. I hope that just made sense. I can have an animal breathing, normal respiratory rate, normal respiratory effort, and potentially have a crappy pulse oximeter reading, which is a representation of oxygenation. So they're not, I mean, they work together, but you can have issues that affect one or the other. So it's not as simple. So I do want you to be aware of, how do we monitor these things? So first, if we talk about circulation, obviously, which is super important, is your constant awareness of your heart rate and rhythm, looking at your perfusion, looking at ECG blood pressure, and assessing that the whole time. Now, if I go, how do I assess circulation? Well, the first thing you want to look at is heart rate. your heart beating. Now, you can do that by physical assessment, which palpation of an apical pulse is you putting your hand over their chest and feeling their heart, because the apex of the heart touches the thoracic wall on the left side. So if I say get an apical pulse, you're not feeling an artery, you're actually putting your hand on the heart. And you could also palpate a peripheral pulse. Now, when you put your hand on the femoral artery, when you guys put your hand under their leg and you feel a pulse, that is technically a pulse rate. That is not really a heart rate. If you're going to be technical, to get a heart rate, you have to feel the heart beating on the chest or listen with a stethoscope to the heart. Now, hopefully your pulse rate is equal to your heart rate. But, you know, I'm a little ticky-tacky about that. It's like one means one thing, one means the other. You need to auscultate with a stethoscope. The other thing that we could do is we do use in surgery something called an esophageal stethoscope, which there's a tube, and this is probably one of my favorite monitors, and it's cheap. There's no reason a clinic cannot have one of these. No reason. Unless your boss is like ultra cheap, which would upset me, because you know, it's a clear tube. It passes down the esophagus, and then you have, it looks like a stethoscope without the bell, and you hook it up, and the tubing is in the esophagus where the esophagus passes by the heart. And so you can hook it up without having to reach your stethoscope under the drape and try to like listen to their heart. And that's going to give you a heart rate by auscultation, which again is the most accurate. If you can hear the heart beating, your patient's alive. And that rate is always going to be the most accurate. Now, there are mechanical machines. Obviously, the ECG is monitoring the electrical activity of the heart. It will give you a heart rate based on the EKG. But if any of you have worked with an EKG, and the EKG heart rate tends to fluctuate, an EKG will look at that on the screen. You'll see the PQRS. It will take a snapshot of that, and it will calculate the heart rate based on what's on the screen. So sometimes when people are scrubbing, the ECG goes off the screen because of movement, and then all of a sudden you get this really low heart rate. Well, it's because the ECG was not on the screen. It's counting what's there. And so all of a sudden you get this really low number. Then the ECG comes back and you get this really high number. It's looking at what's on the screen and it's estimating the heart rate. So the more movement and interference you have, the more irregularities there are going to be in the heart rate. But again, what I tell the student is if your ECG looks funky, if your number is freaking you out, put your stethoscope in and listen. Does what you hear match what you see? That's the fastest way to determine, is there a problem? That's common sense. I'm like, because I've had people stare at an ECG and freak out and not even pick up a stethoscope. I'm like, the only way you're going to tell if that's accurate is listen. Now, if your heart rate's all over the place and it matches, we got a problem. But 9 times out of 10, there's just interference, and what you hear will kind of confirm that that's not accurate. But that's the fastest way. Now, your blood pressure monitor, it's not going to give you a heart rate. It's not going to give you a heart rate value. But remember, the heart's job is to pump blood out to the body and maintain perfusion. If you have a good blood pressure reading, you assume the heart's doing its job. So I can look at blood pressure and I can evaluate heart rate. And let me say that there's a lot of times where heart rate has not been, you know, maybe the heart rate's low, but probably one of my favorite doctors I work with, my criticalist, I had a low heart rate. I was kind of starting to think, oh my gosh, why is this heart rate so low? And he was like, what's your pulse ox? What's your blood pressure? And all those values were good. And the color was good. Pulse quality was fine. And he goes, if all of those are good, why are you worried about the heart rate? Obviously, the heart's doing its job if I have good blood pressure, if I have good color, if I have good pulse quality. So those are kind of a way to go back and look at your heart and say, is it doing its job? Now, I will get into, there are what's called, or there is what's called an interarterial catheter, and that will measure blood pressure directly from an artery. That is the most accurate, except that's an advanced procedure. You have to have a monitor that's capable of doing direct blood pressure. The one at school, we can do it. You just have to order the parts for it. But if you're working in a critical care situation, advanced surgery situation, we put these in at Purdue on our more critical cases. We would put in what's called an art line, put a catheter in an artery, and then we would monitor blood pressure directly. Most of the time, blood pressure, you guys, the oscillometer, you're going to see the cuff on the leg, and you hit the button and it inflates and it gives you a reading, and that's called indirect blood pressure. So it's just an estimation of blood pressure, which can be okay. But if you have a really critical case, and if any of you are thinking of getting into equine or you want to do large animal anesthesia, every horse is going to get an arterial catheter because it is so critical that they have good perfusion to their muscles. So definitely in horses, art lines are considered routine. I mean, they put them in like every case that's getting anesthesia. In small animal, it's going to be more special cases that are probably going to get an arterial catheter. But it is the most accurate way to, and on a side note, if you have an arterial catheter, you can draw a sample and do a blood gas and measure oxygenation. So it gives you another benefit. Sometimes we put it in because we wanted a blood pressure, a direct reading. Sometimes we put them in respiratory cases because we knew we were going to be doing blood gas measurements. And it's easier to have a catheter than stick an artery every time you want a sample. So, there's a couple of reasons to do it, and I will talk about it. So the thing that developing a monitoring plan is, what do you do when an animal has a low heart rate or a high heart rate? And what are some reasons that it can happen? So bradycardia, which is obviously a low heart rate, is sometimes seen when, most anesthetics are, most of them, if you look them up, are cardiovascular depressant. I mean, that's one of the side effects of practically every anesthetic. I've told you guys, the heart rate will be lower. What you have to develop is this heart rate too low? So the way I look at it, the problem with dogs is they're all over the place. Now, I will tell you, cats that are below 100 beats a minute are extremely bradycardic. That's a big red. I don't like cats' heart rate below 100. I just don't. In a dog, it's really going to vary on the breed. Now, if I have a Chihuahua, and they normally have a fast heart rate. If I got a Chihuahua that's below like 140, 120, I'm kind of like, that's low. If I have a Great Dane that has a heart rate of 120, I'm like, that's really high. Or like if I get a heart rate of 60, if it's a Chihuahua, I don't like that at all. But if it's like a Great Dane, a German Shepherd, a big dog, I'm like, a heart rate of 60 is probably pretty darn good. So the problem is in dogs, there's not like the magic number. In horses and cats and cattle, you get universal numbers because, horses, there's a difference between an Arabian and a thoroughbred and a draft horse, like a Clydesdale. Clydesdales are like the Great Danes of the horse world. And I would say like your thoroughbreds and your Arabians are your like Jack Russell Terriers of the horse world. They're flighty, high strung, but you don't see in those species the variation in heart rate like you do in dogs. So in dogs, what I do is I'm like, what was their heart rate the morning of surgery? So I do a pre-exam, get a heart rate, and say it's 140. So say that dog, and they could be a little excited, but if their morning heart rate was 140, did their heart rate drop 50% of their morning heart rate? So for that dog, I don't want it to go below 70. That's 50% of 140. So that's kind of my bar that I set in my head. I'm like, what was your morning heart rate? I don't want it to drop below half of that. Now, if it goes from 140 to 120 to 110 to 100, that's kind of the path of getting under anesthesia and getting depressed. But then sometimes you have heart rates that will extremely plummet fast. Like it'll be 140 1 minute and then it'll drop to like 60. And I'm like, whoa, there's not a lot of things that do that. But I do want you to know that your alpha 2 agonists, which is xylazine and dexmedetomidine, your dexdomitor, it will cause severe bradycardia. So for example, if I have a dog that has a heart rate of 40 or 50 and it was much higher, one of the first things I look at was, did this dog get an alpha 2? Did this dog get xylazine or dexdomitor? Or this cat, you know? If the animal got that drug, I'm like, okay, it's more than likely from that medication that they're bradycardic. If they didn't get that drug, then I'm kind of like, are they too deep? Are they having an adverse reaction? Do you guys remember what happens during vagal stimulation? What does vagal stimulation do to the heart rate?
It lowers it, doesn't it?
Yep. So that's the other thing I look at. Well, okay, who is Blitz the one? This is how bad I am with names. That's who we were just talking about, the collie.
Yeah,
Yes.
he's the crazy one, the little
Crazy.
tiny one.
Yeah, very slender, collie-like face. Yeah, I don't know what he is, but when I look at that face, I think collie. As soon as he walked in the room, I went, you're going to be sensitive to my drugs. When we got him in surgery, and he was doing okay in the prep room, his heart was low with the dexdomitor. We used a quarter dose atropine in the prep room, brought it up a little bit. And when we got in surgery, he was like 80, 90 beats a minute. And I was like, that's decent. I like that. And Dr. Ritz started doing the neuter, and she started like popping out the testicle, and she started doing her clamping. All of a sudden, the heart rate went 70, 60, 50, 44. And I was like, and just like that, just like, and I was like, turn him off right now, or like put him on a 0.5%. We turned his anesthetic down. He had very loose jaw. And I was wondering, now normally with pain in that part of the procedure, normally the heart rate goes up. I was kind of perplexed because I'm like, well, the dexdomitor's worn off now. I mean, we're an hour and a half in. I expect, so then I didn't know if the tugging, sometimes tugging on things during surgery will cause vagal stimulation. So I went and had the circulator. I said, go get me atropine. Go get me the atropine, bring it in. Gave him, and the blood pressure started dropping too. So we gave him a dose of atropine. Heart rate came up nicely. I kept that dog, I think he was on 1% or less for the whole neuter, which is pretty low. So I don't know. I just, that was jarring to me. I was like, you know, that's a little low. So I think when it starts to plummet, vagal stimulation will cause a plummet. You treat that with atropine. If the heart rate's just gradually going down, you can, if your dog's on general anesthesia, you can turn down your anesthetic and see if it comes up. You know, because one of the reasons for bradycardia is they are too deep under gas. So I kind of look at, did they have a drug that causes bradycardia? Is the doctor tugging on? So vagal stimulation is not on here, so you should put that in your notes. Is something causing vagal stimulation? Are they too deep? The other thing you should write on, well, adverse effects of drugs. Sometimes patients just have an adverse effect. You cannot predict that. But the other thing is hypothermia. Hypothermia will cause bradycardia because as the body gets cold, it goes into preservation mode. It starts to kind of like, you know, things are going to slow down to preserve. And so the colder they are, the lower their heart rate. You also need less anesthetic with hypothermia. So taking, and I'm talking like, you know, the dog, we put the cat in surgery the other day, and she was like 98 degrees. And the student was like, ooh, 98. And I was like, I like that. I'm like, that's not bad. When I'm talking about, and I know Dr. Paul doesn't like them at 96. I'm like, well, when I was at surgery at Purdue, I had a patient get down to 88 degrees. It was a little Yorkie pup, and that was pretty severe. So, you know, definitely like that patient was on almost no anesthetic. It was so cold. So think about that. Now, if we get into tachycardia, and so now the heart rate's going too high. Now in a cat, you know, it can vary, but we're talking about heart rates up in the like, you know, it's getting 160, 180, 200. You're getting a spike in heart rate. In a dog, it's going to vary, but all of a sudden it's going up. Well, the first thing I think of, did they have a drug like an anticholinergic, which is atropine or glycopyrrolate? If you just gave atropine, sometimes when you give atropine, the heart rate goes too fast. It'll actually go too fast. Cyclohexamines is ketamine. So did the animal have any ketamine in the protocol? Because ketamine will increase heart rate. Ketamine is a cardiac stimulant, so it'll cause an increase in heart rate. One of the main things, and this is where most people think, is that they're not deep enough. If they're too light, if you now, you know, like when I turned down Blitz, I was expecting when she clamped to get tachycardia, because sometimes when they get to that part of the procedure, I get sometimes a tachycardia, meaning maybe they're a little light, maybe, and then pain. So if they're not deep enough, they're going to be able to feel pain, and you'll start to see an increase in heart rate. Now, the one thing I don't want you guys to ignore is if you assume every time the heart rate goes up that they're light or they're painful and you turn them up, what if they have really low blood pressure? Or what if they have blood loss and shock? Because what happens when an animal experiences blood loss or they're going into shock, the heart rate increases to try and pump out more blood. The problem is in blood loss, they don't have enough blood. But the heart's natural reaction to a low blood pressure is, let me pump more blood into the pipes. Let me pump more into the blood vessels. So you really have to look at your other signs. If they're feeling something, if they're inadequately deep or they're painful, a lot of those animals' respiratory rate will go up too. So they go, you know, they start huffing and puffing and the heart rate goes up, and then you're like, okay. But if I've got tachycardia and I have no jaw tone, if I have low blood pressure, if I have a normal or low respiratory rate, it's probably not pain. It could be that they have low blood pressure. So you just can't ignore, because if you turn an animal up that has low blood pressure, you're going to make the blood pressure worse. Inhalant anesthesia causes vasodilation, which causes low blood pressure. So that's not what you want to do at that point. So normally what I do, if they have low blood pressure during anesthesia, I turn down anesthesia and I bolus fluids. And sometimes bolusing fluids will boost. I had a really good case where I saw this, and we had a bloodhound, and the dog ate a towel, like an entire towel. Now it came off in giant chunks. I'm like, how did you even swallow this? But the dog had been vomiting for 3, 4, 5 days. The owner kept thinking, oh, he's gotten it up in the past. He'll get it up because he's eaten things before. Anyway, didn't get it up this time. So when he came in and I lifted his lips, he was super tacky. Like, the doctor wanted to rush to surgery. I had wanted the dog to have fluids before surgery, but he's like, no, we got to cut now. And I was like, okay. Now a bloodhound, if you don't know what a bloodhound is, they're very large. Like, this dog was like, I think it was like 110 pounds. He was a big bloodhound. When I knocked him out, he had a heart rate of 180 after induction. Okay, 180 is cat heart rate, not 110-pound bloodhound heart rate. And if you think about it, if you remember from anatomy, this is physiology, this is important. When the heart constricts, that's when blood pumps out. When the heart is in diastole or relaxation, that's when it fills. The bigger the heart, the longer it takes to fill with blood. Hence, your large breed animals, dogs, horses, whatever, they have lower heart rates. Because if you think about it, when it beats, it has to spend a decent amount of time in diastole to fill. So if you think about this logically, think clinically, if I'm a big bloodhound heart and I'm beating 180 times a minute, what does that do to my filling time? What does it do to the time the heart is in diastole?
Makes it slower.
It lowers the ability to soak up enough blood to be able to pump the blood out.
Amen.
There's no blood to pump out because it's not getting enough time to fill up.
Exactly. It decreases filling time. And I think Kayla and Megan, you guys were trying to say, yeah, it's so what it's doing in effect, the next heartbeat, the next time it beats, it's not pumping out as much blood because it didn't have enough time to fill. Now, I think, so when I got into surgery with this dog, it has a really high heart rate and I was having really crappy blood pressures. And I'm trying to pump in IV fluids. I ended up getting, the doctor says, fine, go ahead and give it, Hedistarch and bolus fluids. And eventually, like mid-surgery, I got the heart rate to like 140. It still wasn't perfect. I mean, I would have liked a heart rate around 100. But I did get blood pressure to eventually come up and heart rate to come down. And that was a normal physiologic reaction. So I think the reason that dog was so tachycardic is the dog had been dehydrated. And then what happened is the anesthesia caused vasodilation. And so the heart rate sped up because it was trying to combat the low blood pressure. But the problem is the dog didn't have anything to pump. The heart's pumping, but the dog is dehydrated. So we have to reestablish hydration. So I was giving like double dose fluids, like double what I would do a normal surgery patient. Plus I started giving Hedistarch, which held the fluid in. And then, like I said, in about 20 minutes or so, that heart rate started coming down, blood pressure started improving. So, there's ways to treat what we suspect is the problem. But again, the tachycardia in that patient, the patient was asleep. It had no jaw tone, no blink, no reflexes. Respiration was normal. So nothing about that patient corroborated that the tachycardia was from pain, if that makes sense. Nothing in that scenario pointed in another direction. It all pointed to me, and also knowing the history of vomiting for that many days, tacky mucus Now, a bloodhound is never going to have a tent because there's so much skin it does snap back. So the dog didn't, but you could feel the gums, you could see the sunken eyes. Like in the history, we were like, okay, you're massively dehydrated. So we had to play catch up. And again, I was not in agreement with the surgeon. I wanted to wait to do this. The dog wasn't super critical at that moment, but the doctor had time to do the surgery, so we had to go to surgery. So again, just things to think about. Things to look at also, indicators of circulation. First of all, you look at your rate. What is the rhythm of the heart? Is it a normal rhythm? You look at this with the heart rate. Obviously, if it's a pattern, it should be like a good song, and you hit this pattern in your head. Now, sinus rhythm is obviously, it's extremely normal. Sinus arrhythmia speeds up with inhalation, slows down with exhalation, and both of those are very common during anesthesia. It can happen. And again, it's a normal EKG tracing. I call it a regular irregularity. It's an irregular heartbeat, but it happens on a regular basis. So it's kind of a regular irregularity. And that one, I don't have to confirm. I mean, you'll see it on the ECG, you'll watch breathing. Now, when we start to get into, you need an ECG if you suspect heart block. And now heart block is you're listening and then all of a sudden you don't hear something. and then you hear it again, there's dropped beats. Now, first degree heart block, there are no dropped beats, there are just pauses. And that sounds like a Brady, or it's an arrhythmia that's associated with a slow heart rate. So it's called a Brady arrhythmia. Second degree is where you get those P waves without a QRS complex, and that will sound like a dropped beat. Now, sometimes these arrhythmias, these drugs can cause arrhythmias. Sometimes atropine, now atropine treats heart block, but sometimes when you first give it, it will be worse for a moment or two before it gets better. And this happened to a student once, and we were in third degree heart block. There was multiple P waves without a QRS, and I drew up the app, and this was when I was at Purdue, but I drew up the atropine. I said, give it. When she first gave it, the heart rate kind of went down, and we saw more P waves. And she was like, wait, give me the atropine. We got to give more. And I said, nope, wait a second. And in about a minute or two, it got rid of the heart block, heart became normal. And I said, if you would have given another dose on top of the one we just gave, you probably would have caused a massive tachycardia. Sometimes it just takes a minute or two. It's kind of like, I told these students, I said, it's like if your car is out of gas, and when you first put gas in it, if you ever completely run out of gas, and then all of a sudden you go to start it, and it's like, and then it like kicks in. It's kind of like if I have a dog in heart block and I give atropine, sometimes it goes down a little bit and it gets worse, and it's like a sputtering car, and I'm like, and then all of a sudden the heart goes. So it's touchy. Nobody likes to be in that scenario. I'm always kind of biting my nails a little bit too. I'm like, come on, heart, come on. And then it kicks in. But I'm like, you just got to be patient a minute. Let it kick in. It's going to fix itself here. So drugs can cause some of these arrhythmias, especially anticholinergics, alpha-2s. You know, we don't use barbiturates anymore. Cyclohexamines, ketamine can cause some of it. But also heart disease, trauma, dogs with a GDV. GDVs typically come in with these Brady arrhythmias due to their effect, the pressure on the vessels, the pressure in the, from the GDV on the thorax, hypoxia, high CO2. I mentioned, actually I want to stop here because I want to talk a little bit more about these monitors, but I'll talk about, I already kind of explained the esophageal stethoscope to you, but we'll pick up here. Are there any questions? Okay. Well, if you don't need anything, we'll pick up tomorrow. I'll get this video converted with yesterday's video, get them posted, and I'll think about the test and stuff. But for right now, just work on your sheet, and we should be good to go.